Behavioral Health Network Grand Rounds. I am extraordinarily excited to be looking, and I know he can't see me, but I can see Dr. Dike, Dr. Charles Dike, who's with us today, and I'll introduce him in just a moment. But a couple of ground rules, just as people are used to, we'll hear his presentation from 12 until about 1, and then we'll have 15 minutes for discussion, which I will have to end right at 1:15. I have a hard stop. People are welcome to send their questions to me in a variety of ways, and this is an evolving process. So you can use the chat feature, which people don't tend to like to use, but it is that square bubble, and we do check it on the top left for those that are on the computer. It's hard to do that on the phone. You can send me an email, which most people do. You can text me if you have my text. All of those things are good. And I was just hearing from Bill that those of you that are coming in on Chrome and not the app, which I haven't learned how to do yet, apparently there's a raise your hand feature now at the bottom bar that gives you those options. So you can certainly do that and raise your hand. And Bill will let me know that you've done that, and then I'll unmute you. So I want to try to get into giving Dr. Dike some time here. So as you can see, he's got his slide up. He is currently the medical director for the Office of the Commissioner at DEMAS. He's an associate professor of psychiatry, law and psychiatry division, and associate program director of law and psychiatry fellowship program at Yale. And I'm going to read just a list briefly from his bio on the Yale site. He completed medical school in Nigeria and psychiatric training in Birmingham, England. After residency, additional residency training at the University of Illinois, Chicago. He did fellowship at law and psychiatry at Yale. He obtained a diploma in clinical psychiatry from the Royal College of Physicians and Surgeons of Ireland and was awarded membership of the Royal College of Psychiatrists of England in 1998. And you're starting to see that part of his experience comes from a kind of worldly sense of what's going on out there. And he also has a master's in public health from the University of Illinois, Chicago. Past president of Connecticut Psychiatric Society, where I have worked with him for many years, a distinguished fellow of the American Psychiatric Association, and all of those letters that are after his name. Fellow of the Royal College of Psychiatrists of England, fellow of the American College of Healthcare Executives, and is vice chair of the Ethics Committee at the APA, which is a very big deal. Vice president of the American Academy of Psychiatry and Law, editor of the newsletter of Apple, and former chair of the Ethics Committee. I love that, Charles, on the Yale website, that it says Dr. Dike is also medical director, Office of Commissioner. It's an afterthought. Yes. And just on a personal note, absolutely one of my favorite people. So glad that he is in psychiatry. Really lucky to have him in Connecticut. And many of you already do know him. He's never not focused on wanting to build better systems, wanting to give better care, wanting patients to have a better experience of care. He has incredible energy, and people follow that energy and build good things around him. One just personal note, having known him for a number of years, I had a wonderful chance to visit with him and his wife in a church that they're involved in New Haven, and they do coaching of the debating teams for the young kids that are involved in this church. And he happens to be an extraordinary debating coach, I think probably good at debating himself. And it was just, I've never seen anything like that. These kids, I can't remember how they were probably 10, to 12 years old. And it was just mesmerizing and speaks to his devotion to the community and youth and working with people that really do need help. So with no further ado, I'm going to turn it over to Charles and let him talk with you, and then I'll come back in at around 1 o'clock. Dr. Dike.
Thank you so much, John. I almost looked back to see who you were talking about. Such a generous introduction. One of the most difficult things for me is I actually don't know what I look like because I can't see myself here. And I am just going to assume that I don't disgrace myself in terms of
You
how
look
I look.
great as always.
It's really an honor to be here at IOL to give these grand rounds. John obviously is one of my most favorite people here in Connecticut. And so it's really my pleasure to be here. Let me go through some basic, normal things that you do these days, no disclosures. And I have this QR code at the beginning and also at the end. So I'm going to leave it on for the end. I also say that because I wear too many hats, everything I'm going to say today is all about me. It's from me. These are my views, no official policy or positions from Yale or the state or anywhere else. And so the question is, this is a dramatic picture that I think leads us to this conversation. Why is this an important topic for me? Now, I think I should give you a little background first. I was, right after fellowship, I worked at Whiting Maximum Security as an attending psychiatrist. I worked there for about 4 years in that capacity before I became medical director, and then I became the overall director of the forensic hospital in Connecticut. But that 4 years, when I worked as an attending psychiatrist, I worked on the unit that was termed the ground zero of maximum security. It was the unit, the most challenging, the most difficult, dangerous, refractory patients were all pulled onto that unit for a particular reason that predated me. But as a result, they could not find a doctor to cover that unit for almost 2 years before I came. And I didn't know all of that. It turned out to be a wonderful experience, but there I was working on this unit with the most challenging patients you would ever see. Anyway, so that's fine. I began to understand this dangerousness. I had encounters with people who were too dangerous to be in a hospital. Mostly from the point of view of danger to others, very violent. And also some of them were extremely violent toward themselves, so that even for their own self, it was very hard for them to be managed in a hospital, in addition to danger to other people. But this picture here shows you what happened when I was director of Whiting. We got a call from the courts that somebody was going to be sent to us who was to come in for restoration to competency. I will describe these terms later on. But that there was something unique about this individual who was coming. Individual was a death row inmate who had murdered many people. But somebody had challenged the sentencing that got him to death row, that convicted him to death row. And as they challenged the sentencing, they were going to look whether they might have to have a rehearing of sentencing, and then immediately it became clear to them that he was no longer competent. So he wasn't competent to participate in that rehearing of sentencing. And the forensic hospital is the only place where you have competency restoration. So we were called that this individual was going to come in to be restored to competency, to have a rehearing for his sentencing, and so on and so forth. So we said, no problem. What I didn't know was that he was a death row inmate. And when they brought him to Whiting, they brought him exactly like this: armored vehicles, sirens, police in riot gear like this, military police, all kinds of weapons. They brought this guy. It was a spectacle. They brought him to our hospital. They drop him in front of our door and says, here's the man, you restore him and, bring him back to us. And then they left. Now, I don't know about you guys. They bring somebody like this who's extremely dangerous, who's on death row, and they just drop him casually into the hospital like that. And so anyone who knows me knows that it's very difficult for me to be flustered by anything. But I have to tell you, on this date, I look like this. What the heck am I going to do with my life at this point? This was so dangerous. What if this individual needed to go to a hospital, he had a heart attack or some other medical condition for which he needed to go to Middlesex Hospital. How are we going to get him from where he was to the hospital, given the amount of escort and the different kinds of people he came with? He was definitely a dangerous person, which we eventually got to see. It was very hard for us to manage him while he was in the hospital. So I pulled some of my friends together who are across the country, who run psychiatric forensic hospitals. I said to them, listen, we need to do a talk on managing very dangerous patients in a hospital who really should be in prison, but they are in a hospital with us. How should we do that? That's how this came about. Many people came and we had a talk on it. But this is just my aspect of it, and I put a little from other guys, but mostly my aspect. The guy you're looking there, believe it or not, it's me, even though it looks white and he's pulling his hair, and I don't have hair. It used to be. I guess that's what I looked at that time. So how did we get here? When we say dangerousness, it wasn't always like this. Early on, to get admitted into a psychiatric hospital, all you needed was a need for treatment model. Somebody needed to be treated in a hospital. Sometimes they fudged it and they railroaded you into a psychiatric hospital, even if you didn't need it for whatever reasons they had. But at least there was a model that says an individual is ill, they need to be in a hospital. Well, from the 1960s, there were all kinds of changes were happening with civil rights, with attack on the psychiatric hospitalizations, with the Community Mental Health Act of President Kennedy. All of those things led to a dramatic decrease in psychiatric hospitalizations, such that if you look at the numbers there, in 1955, we had over 500,000 public psychiatric beds in the U.S. with a population of 164 million. By 2005, that number had dropped dramatically to only 50,000, while the population had almost doubled. So there was a dramatic decrease in the number of patients who were in a hospital. Around that time, around 1964, the standard for coming into psychiatric hospitals began to change, starting with Washington, D.C., where it became a dangerousness standard. So now, the only way you can get into a psychiatric hospital is not so much that you just need treatment or you need care, but people have determined that you present a danger to yourself or a danger to others, or that you are gravely disabled, which actually also means that you have a danger to yourself, that is the reason for you to come into a hospital. So already we are beginning to hear the word dangerousness associated with psychiatric hospital. But so here's what happened then. The consequences of massive depopulation of psychiatric hospitals is that many of them began to have what we call nuisance crimes, like breach of peace, larceny, small larceny. You steal a purse or you steal cigarettes, or disorderly conduct. As a result of their psychiatric disorder, they ended up in prisons and jails, such that ultimately prisons and jails became large psychiatric institutions, if you will. And it's always said that the largest psychiatric institution in the U.S. is LA County Jail. So these individuals who were in the psychiatric hospital, as a result of their mental illness, had nuisance crimes, ended up in prison, and that led to all kinds of consequences because they learned behaviors in prison that were not good enough or good behaviors. And as noted by Coyd and Ulrich here, the characteristics of forensic patients in prison mirror those of non-psychiatric inmates in prison, because they also include intimidation, violence, exploitation, manipulation. So they learn these behaviors just by being in prison. And somebody also said down there, even offenders with no history of psychiatric disorder, history of violence before they went to prison, upon getting to prison, learn how to become violent, and then their dangerousness levels rose very high. So this hasn't really been a good thing for our patients going into psychiatric hospitals. Who are these dangerous patients? Most of them are men, but I tell you, I have seen some women, and those women that are extremely dangerous They really are, and one has to be very careful. Most are young to middle-aged men. Lots of antisocial personality disorder, substance use disorder. Many of our patients have prior correctional experience. You may or you may not know it, but many do have it, either through being housed there for a short period for competency restoration evaluations before they come into hospital, but many have a history of some correctional experience. Obviously, they are very difficult to be discharged and so on. Now, what are the difficult behaviors? By the way, I'm going to rush through this. There's a whole lot to say on this topic. I'm going to just try to be as quick as I can, given the time frame we have. Some of the problematic behaviors encountered are contraband, manipulation, extortion. You know, they really extort things from other patients and staff. Bullying, intentional targeted acts of aggression and violence, willful violation of hospital rules. And of course, some people have sexual assaults, very dangerous sexual assaults in a hospital, and so on and so forth. Fire setting, even in a hospital. Very quickly, the types of violence that we generally like to look at violence from two different angles, whether they are affective violence, which are also impulsive, sudden, often related to an emotional reaction, perceived threats, you know, either someone who has bipolar disorder, easy irritability, someone who has intellectual disability, misreading cues and reacting or acting out violence. So that's affective violence. And then you have the other one, which is predatory violence, where it is planned, purposeful. You have guys who stalk you, who, you know, really more in the line of people who you would consider psychopathic or sociopathic or severe personality disorders in general. So how do you know, but just wait for a minute, how do you know that an individual is too dangerous for a hospital? That's a really large term, because someone might be too dangerous to be in the emergency room, because as you know, the emergency department is very active, you know, things up and down, lots of noise, lots of movement. That could be very difficult for a patient. And some of our patients could react violently in the emergency room, but they might not be actually dangerous once they get onto the inpatient unit. I have seen so many of that happen as well. Now, a patient in an inpatient unit might also be dangerous on that unit because of the composition of patients on the unit. Maybe the patient himself might be very vulnerable, or there might be other vulnerable patients on the unit. Maybe there's a patient who's been provoking this new dangerous patient through all kinds of means, and you would not know it until you really dig down to understand why this individual is acting out. So sometimes it's just what is on the unit. The composition of patients on the unit, the behaviors of patients on the unit might actually be provoking the dangerousness. Dare I say there are some staff that might also provoke patients. I have seen those things, and some of you know that this is true. What I find really fascinating about this is that many staff people know the staff people who provoke other patients, but there could be staff who provoke patients to danger. Now, if the volume of patients on your unit, if you have overcrowding, is extremely tight, there's the body space, as you know, the space is wider, you know, if you have a psychiatric disorder or violence. But if it's crowded and the census is really high, that might also trigger some people to violence. Then the ratio of staff to patients, if you have very small number of staff, lots of patients, that might also lead to difficulties. Or if you have a large number of float staff who may not actually know the patients very well, and therefore might not have any rapport with them or be able to de-escalate them or understand what their issues are, that might also be a problem. Last thing I want to just highlight here very quickly is the gender ratio of staff. You know, is it more females versus more males and vice versa? And people make all kinds of comments about this, which I will come back to address later on, whether there's actually any validity in it. I've heard male staff sometimes say to me, we can't manage this individual because all my co-staff members are women. And I mean, how can you manage this? And I've heard all kinds of things like that. But let's come back and address that particular point, whether there's any value to it. What tends to happen, however, is that all of these things lead to a significant problem. Issues of concern on the unit. When you have an environment where there's someone who's dangerous, it leads to what I call a toxic environment, directly impacting staff and patients. Everyone is walking around on eggshells. People are worried about what will happen next. It's very difficult. You can pluck the tension on the air with like a string in those environments. Obviously, if you have also a really dangerous person on your unit, they might disrupt the orderly operation of the unit. Implementation of any kind of care or programming might be disrupted. And, just the idea of even trying to maintain safety and security while cultivating rehabilitation of patients could be very difficult. And then you ask yourself, can a patient be really effectively managed when that person's behavior is deemed too dangerous for the hospital environment? And that's when people begin to talk, and then that's when people begin to call me. So all roads at that point will lead to a state psychiatric hospital. Here, all roads are leading to Rome, because people are saying our type of hospital can't manage this individual. We have many elderly people, all kinds of mixes of things. We need this individual to go to a state hospital. But where do they come to? And I'm just going to run through this. Who are the patients that are currently housed in those areas that these guys might come to? You have individuals who have been found not guilty by reason of insanity. They have committed the most heinous of crimes sometimes, but people have determined that they committed these crimes as a result of psychiatric disorder, and so they have been actually acquitted of their crimes. So they are not guilty by reason of insanity. They are in a hospital. Some people are sent for competency restoration, like the guy I told you earlier, who was a death row inmate sent to us for competency restoration. Others are people who are already DOC patients, but who have severe psychiatric disorder that maybe cannot be managed in DOC. They are sent over to this hospital to treat them, stabilize them, send them back to DOC. But I want to highlight a really important group of people in these hospitals. Like, they are civil patients. These civil patients have not done any criminal behavior, but they are there by the dint of just the fact that they are extremely dangerous and cannot be managed in less secure environments. They are not less difficult than these other people. Trust me, sometimes even more difficult than them. What many people don't understand is that there are significant challenges to managing people in a hospital like this. I've laid them out in that format, but I want you to understand that the regulatory agencies that oversee forensic hospitals use exactly the same standard as they use for regular hospitals. Whether it's CMS, whether it's Joint Commission on DPH Disability Rights, all of them use exactly the same metrics. It's not different. It's not because you're forensics, we give you leeway to use more of this than that. So the staff who are in these forensic hospitals are dealing with these patients using exactly the same limits set on them by these regulatory agencies as you have in regular hospital. And these patients' Bill of Rights, and it's very important for them. We understand that the environment, there's a lot that has been written more recently about the environment that is conducive to managing dangerous and difficult and challenging patients in a hospital. Most of our forensic hospitals are really old, and the environment is really old, and they don't meet exactly what people are talking about here. However, if you had the opportunity, you would want what they now call a trauma-informed environment. Why is a trauma-informed environment important? It's important because literature shows that up to 90% of our patients, who are in these hospitals, especially in forensic hospitals, have a history of severe trauma right from childhood up until when you meet them. And so many of them are suffering from effects of trauma, some PTSD type symptoms, complex, sometimes mixed with all kinds of psychiatric disorders, and therefore not quite clean. But on the other hand, the staff also are victims of trauma. Literature also shows that nursing staff in their lifetime of work about 70% of them would have experienced significant trauma, and about 20% of them would be dealing with PTSD. Therefore, what tends to happen on this unit is that everyone is tense, on edge, just irritable, reactive, and so on and so forth. So a trauma-informed environment might be helpful. What kind of lighting do you have? Is it bright? Decorations, colors, calming, sensory, relaxing scenery and all that are things that are really important in that kind of environment. See, open spaces, because if it's closed in, it can create, can trigger some of these reactions I mentioned about trauma, related to trauma. What about housing? Is it single rooms or double rooms? I can tell you that for this very dangerous and difficult patients, you really need single rooms many times, at least until you are able to manage them enough to be less dangerous. They can then room with other people. What about number of patients on the unit? I've talked about crowding and overcrowding. On my unit, which was the ground zero of maximum security, so maximum security hospital is already filled with people who have significant dangerous behaviors. And then you have the ground zero, which is the unit that has the most dangerous of the dangerous patients in the maximum security. So the number of patients you need really has got to be about 12 or so, lower numbers and higher staff ratio to manage them. Noise level. The more the noise level, the more the difficulty. That's why emergency rooms can be quite problematic. A lot of attention should be paid to what kind of materials people have access to. Sharps coming in from outside, or sharps, potential sharp material that are already in there that can be converted to very dangerous weapons. Now, what about the staff? I've talked about decreased staff ratio to patient. Really high staff-patient ratio. Talked about training. I'm going to come back to some of this in a minute. But the composition of staff that you need, nurses, rehabilitation therapists, PTs, music therapists, psychologists, social workers, and so on and so forth. Now, let's address this gender issue here. What I mentioned before, where people say to me, oh my God, we only have women here, and it's going to be a bad night, or we can't manage this dangerous person. Actually, the literature shows, and my observation shows, that for some reason, even a frail-looking, smallish, older woman has been able to de-escalate the most dangerous of patients. I'm telling you, it's very difficult to understand. But when I have talked to these patients later on, they've said to me, am I a punk to attack my grandmother or to punch a woman? There's nothing to be gained by doing that. And so these people have been able to reach them in ways that very bulky-looking men might not be able to reach them. In fact, if you're that kind of a man, as your staff, you're big, you're huge, you're bulky, you might actually present like a threat to these individuals who already see threats everywhere, and they're more likely to act out, to attack you before you get to them, because they're already perceiving you as threats. So when I hear people say to me, Doc, I'm not really happy with the number of patients and staff I have, there are more women here than men, I really take it with a pinch of salt, because it's not quite what people think it is. And I have found that many times women actually do a better job of de-escalating these individuals. And men might actually think the best thing to do is to show them who's in power, who's strong. And that could be provoking and lead to bad outcomes. An issue that happens many times, and I don't know about you guys, I know that it's more with public systems, is when you have you have a unionized staff. And, I love the idea of union. However, sometimes there could be a problem where you have a bad apple, and everyone knows who this bad apple staff is, but nobody can get rid of this bad apple staff because of all kinds of things you have to go through to get rid of those kinds of staff. And one bad apple, as the saying goes, spoils the bunch. So that could be a real problem, and it becomes really important to figure out how to be creative in making sure that this one bad apple doesn't spoil the bunch. Supervision of staff is extremely important. These are high-pressure areas, high-intensity areas. You need an opportunity for staff to be able to talk to somebody else about what they are going through, about what's happening. To a lot of supervisors, when something bad might be going down, and so on and so forth. So you really need this outlet for staff. You also sometimes need what I wrote here as process groups, which we're all familiar with in residency, where, early in your residency year, you and your colleagues and your cohort peers, you sit around and just vent and talk about things that are going on in the protected environment, and it's okay. You need opportunity for staff people to be able to de-escalate themselves, to vent and feel good, because it's quite a tough environment when you have really challenging patients on your unit. You need a change of culture. What's the culture? Therapeutic and safe environment is really paramount. You can't provide treatment if the environment does not feel safe. It can't be therapeutic. There's always a struggle to balance safety with treatment in these environments. I can tell you that for me, one of the things I found to be extremely helpful is this second bullet point: respect dignity for patients and staff. I'm telling you, the most difficult and the most dangerous patient responds to being treated like a human being, with respect, with dignity, seen as a man. Your word is your bond. If I tell you, if you do this, I'm going to do this, I must do it. And you just have to create that environment where they sense that you see them. And trust me, patients know when you treat them like human beings, and they know when you're not treating them like human beings, and so on. So the first things I did on those units that I was in was to make sure that both the patient and the staff treated each other with respect. If staff people, even joke in a joking manner, called themselves names or did all kinds of things, that, you would say, well, it's like, they're being jokeful, jovial, and so on. I would say no, because we are modeling behaviors to these patients. I would want to be sure that they see that it's a respectful environment. We have all interventions and all kinds of programs to show respect for patients. Staff training, very, very crucial. De-escalation techniques, conflict resolution, lots and lots of training for staff is going to give you a bang for your money way down the line if you do it well, and it's going to be problematic if you don't, on the other hand. One of the things I also found really helpful is to encourage participation of peer supports. The first time I came in contact with peer supports was when I was in Whiting as director, and we went to Canada to see one of our sister-type hospitals over there. And I saw this gentleman describe, I really was impressed with him. He was talking about how to manage and help people recover, how he engages with people, and so on and so forth, how they trust him. And I just was wondering, where did this guy get this training from? Only for me to learn later on that he was actually a patient on that unit for 15 years. He was in prison, he was out, he was in maximum security, he was out, and people just relate to him. When I came back to Connecticut, I sought out those kinds of interventions, and I saw the Perch at Yale had people like that, and I found ways to bring them in. Now, there were some obstacles of bringing people who have a history of imprisonment to the hospital. One of the barriers was we don't allow felons to come in. Well, you're not going to have peers if you don't have people who look like these guys, who've gone through what they have gone through. And so we had to break down some of those barriers to make sure that the peer supports came in, advocates came in. It was really encouraging environment. And people looked at them and felt hopeful and began to see themselves as being on the other side instead of just being here. Difficulty of having enough staff is always an issue. As I mentioned before, if you have float staff, that leads to all kinds of problems. Now, in this environment, there's always a question of security staff. You know that when you have very challenging patients, we've often called in security to participate one way or the other in the management. In a forensic hospital, the police or the security staff have got to be extremely vigilant to watch for objects that can be fashioned into weapons, as I said before, coming in from outside. And also doing rounds to make sure that those objects are also not in the hospital. Reading materials or visual materials that could also encourage or provoke violence. Magazines that are sadomasochistic, all kinds of violent things. clear to watch out for them and be very careful how you manage those things coming in. Materials, even the clothing of staff. Sometimes you have things that are written on them that could be really offensive, that will make some people react violently. Those are things you don't want. To have police to do rounds on the unit when you have a very dangerous person, or posting the police on the unit when you have a dangerous person, is a really challenging issue that requires a lot of discussion, because it could actually either be de-escalating or aggravating, depending on the history the patient has with the police. Sometimes the mere sight of a police person might lead to significant aggressive behavior, because of their history with police, or it might actually help them recover, hold themselves and stop any kind of violent act. So it's not an automatic thing. The idea of bringing in police is something one really has to think about very carefully. Whether or not to arm the police in a state hospital, actually, I was surprised to find that the Joint Commission does not frown on it. It says every hospital has to do what works for them. I really was surprised to see that. But it's also something that one really needs to think about very carefully. Now, let's go to look at what happens when these individuals come in. It's really important to note that the treatment of these individuals starts at admission. That's the most ideal time to start active treatment. It starts with very thorough evaluations, especially by a psychologist as well, looking at, what are the behaviors, the triggers for violence, what kind of interactions, developing behavioral guidelines that might help staff learn how to interact with these individuals very early on. Personal preferences, this is really important. So a basic or initial psychological assessment, it's important, of course, in addition to the psychiatric assessment, social work assessment, nursing assessment, and so on. But just to provide you an opportunity to begin to understand those who will need more psychological evals, those who will need a different kind of management, and so on. So at the beginning, it's really crucial. Now, there are individuals who might need specialized assessment, as I've listed out here, and you will also identify them very early and proceed with that. I'm going to rush through treatment because that's, anyway. So biological treatment, really for individuals who are extremely dangerous and aggressive, the question is, where is it stemming from? Many times it could be stemming from a severe mental disorder, bipolar disorder, other kinds of disorders, psychotic disorders, even severe depression sometimes. So you want to know where the aggression or violence is coming from, what is stoking it. Because if you understand it, then you can provide care. Sometimes it's just developmental disabilities or intellectual disabilities that I've seen the most challenging ones sometimes are people who have those intellectual disabilities in addition to psychiatric disorders and so on. Of course, you have those with personality disorder. It's important to note that there's actually no specific FDA-approved medication for violence. There are medications that might help with irritability, with agitation, all of that. But in fact, to say this is the one for violence, there's no particular FDA-approved. That doesn't mean that we are helpless. It just means that there are so many different treatment algorithms out there. Mood stabilizers have been used, antipsychotics, beta blockers, alpha agonists, benzodiazepines, antihistamines. All of them have been used, but if you needed more, you can actually look at what people have written about them in different places, or you can invite a specialist psychopharmacologist to assist you as well. But biological treatment is really one piece in what is supposed to be a very comprehensive treatment armamentarium of treatment. So you have psychological treatment, very important as well, lots of different types of CBT and skill-based interventions, and different types of additional DBT treatment, skills approach, mindfulness. Start now, I put down there just to shout out to my friend, Dr. Trestman, who worked together with psychologist Susan Semple when they were here in Connecticut in prison, and they developed this whole CBT type intervention for managing violence in prisons, which they have now adapted to psychiatric hospitals. and they are pretty effective. But in addition to CBT, in addition to regular psychotherapy, behavioral management is absolutely crucial. What we're doing is trying to manage difficult, challenging behaviors using all kinds of behavioral techniques, applied behavioral analysis, positive behavioral support interventions, and so on. At least at CVH, we had what you call the behavioral intervention team, a team of psychologists, about 3 or 4 of them, who would be consultants to different units. All the units already have their own psychologist, but those behaviorists will be additional support to them to develop all kinds of treatment plans and behavioral management interventions for our patients. Tracy Sondick, Peter Tolesino, and I wrote an article about the whole behavioral intervention team and how we've been using it in our hospitals. It's also, I need to also mention very briefly, behaviorally based unit. So my unit at that time, when I worked for 4 years, became a social learning program unit. It was converted to a social learning program unit. There's a lot of literature that shows that behavioral units like that can be very effective in managing really aggressive and dangerous persons. So everything that has to do with unit like that, token economy, reinforcement, either positive or negative reinforcement, no punishments at all, shaping behaviors where you reward every minor behavioral change in the direction of the desired behavior is important, and so on and so forth. And this, in addition to very active staff, actually helped in converting that unit from being the ground zero at the time I was there to actually being the least aggressive unit in Whiting, despite having the same most aggressive patients, the same type of patients as before. I cannot overemphasize the importance of OT and PT in management of individuals who are extremely aggressive. Sometimes people just are bored. Sometimes people are frustrated. Sometimes there are so many other things. It's important to learn how to engage them in interventions to manage stress, anxiety, agitation, and so on, so that you can reduce aggression overall in your facility. Things like, therapies I've listed there, very important exercise regimes or therapy, relaxation and sensory modulation tools. Actually, I forgot to put a picture of a comfort room. So there are comfort rooms in different places, which really contain a lot of these sensory modulation tools that help you when you're really getting frustrated, agitated. You can walk into a comfort room, sit down, soft lighting and soft music, and all these kinds of materials might help you feel better and recover quicker. Structured vocational engagement, we know that when you're busy, you're less likely to be aggressive, really important. What about leadership? The leadership needs to be actively engaged in management of a hospital or units that have individuals who are extremely dangerous. I've talked about staff training. Some hospitals have de-escalation teams, not just techniques, not just that the staff are taught de-escalation, but they actually have teams that are, called upon when there's, deployed to units when there's a problem. There are pros and cons to that. Staff wellness, really important to make sure that staff are taken good care of, are acknowledged for their work, and it's important for the leadership to know at every point in time who are the ones that they should be worried about in their hospital. Now, you've tried all of this, right? You've done everything, but yet these individuals are still too dangerous for your hospital. What are you going to do? Is there a path that you can use to move them from hospital to corrections, which is what everybody is probably knocking down your door, telling you this guy needs to go? We're all worried about them. Well, there are 3 parts that are potentially possible here. Many of them have, pros and cons. Restoration to competency to stand trial is the only one, and I'm going to show you that slide in a minute, that has a really clear path to be able to move somebody from a psychiatric hospital to DOC if they're extremely dangerous. Sometimes you might be lucky when staff press charges after being assaulted, and sometimes you might be lucky an individual will be transferred to DOC because they just are too dangerous. But that's just a sometimes thing. If you're lucky, also, you have people who were transferred from DOC to be stabilized. They are too dangerous. You can send them back before you stabilize them. Let's look at what this Competency Restoration subsection P says. It says that this section shall not be construed to require the Commissioner of DMAS to place any violent patient defendant who presents a significant security and safety or medical risk in a psychiatric hospital, right? Because we do not have trained staff to manage them. In those situations, the commissioner should consult with the Commissioner of Corrections to determine whether this individual should be moved. Sometimes if that were to happen, the individual would then remain in the custody of corrections for treatment, psychiatric care, while DMAS will continue to provide restoration to competency services and training for those individuals. So the only way we do that is that we identify this individual who is on a competency restoration status, who's extremely unmanageable, extremely dangerous. The treatment team informs the medical director that this is what we want. Can this guy be moved to DOC? Medical director goes, takes a look, review the case, talk to the individual if possible, then contacts the chief of psychiatry at DOC. Luckily, the chief of psychiatry at DOC right now was my co-fellow in fellowship and also used to work at Whiting. So it's really an easy way to communicate. But you want to make sure that you send only those who need to be there, because the idea of moving psychiatric patients to prison is a really difficult idea for me. And I would really fight hard to make sure that we don't send someone whose behaviors are largely driven by psychiatric disorders to prison, even if they are too dangerous to be managed in a hospital. So that's something to bear in mind. All right, so you have individuals who are competency restoration. You can send them to prison through this particular loophole of subsection P, and when they are calmer and in prison, they can return to the hospital to complete their restoration. All well and good. But what about those guys who are NGRI, who do not have any legal path to be moved to DOC or any other setting, but they continue to present significant dangerousness in their hospital? What are you going to do? What about civil patients who are too dangerous for your psychiatric hospital, of which we see and know these individuals all the time? What are you going to do? So what to do? This calls for significant creativity about how to manage these individuals. Creativity around medications. Sometimes we've considered the use of ECT. This is when you invite specialist psychopharmacologists to assist you as well, and so on, just to make sure that you're covering all the bases. You want to have containment measures. In other words, you want to decrease the opportunity of these individuals attacking other patients or staff as much as possible. If it's possible, you can carve out a section for them on the unit that, one hallway has their room, has their own bathroom, has everything there for them. Being very careful not to construct something that might be termed a seclusion, because once you get into the whole notion of seclusion, you know what that means, documentation every 2 hours and so on and so forth. So you want to create a lot of opportunity for the individual to have free access to things, but you really have navigated those access to things to one area of your unit. There might be a television hall or some other thing in that whole area, but it requires a lot of management to be able to do that. Staffing also, it takes a lot of staffing to be able to manage that individual in that environment. Once in a while, you might need to use restraint seclusion. You have to be extremely judicious how you use it. In those days, when I was attending psychiatrist, there were individuals who were in ambulatory restraints. I don't even know if people have seen ambulatory restraints. 4-point ambulatory restraints for a year and a half straight, continuously before I got there. Well, that is no longer something that is possible. Ambulatory restraints were outlawed in 2006, but you just have the bed restraints or net restraints. You really have to be very judicious how you use it. Some areas have come up with what they call safe wards initiatives, started in England, has now spread all over the world, in Australia, in different hospitals, even here in the US. I know that some of our hospital staff leadership have gone to see safe wards initiatives in Canada, whether or not there are things we can use here. We are thinking about it. Important to actively engage these people in activities. Remember, idle hands leads to more dangerousness, leads to more frustration. So the more you can engage people in stuff, the better for you. So and it's going to require also creativity in the way to do that. Pet therapy might actually also be helpful. Sometimes the most dangerous people, you find them just, break down in front of pets, dogs, and so on. Active behavioral management. I talked about using specialist consultation. Now, let me just make a comment about posting the police or security on units. I've had to do it a couple of times, a few times in the past when I ran the hospital. It's not an easy thing to do because, again, as I mentioned to you, it just depends on the history of the patient. But sometimes you do it to help the staff feel comfortable, right? The staff feels better being able to engage in this kind of care when they know that there's a police person present, or they know that police will do their rounds. Or sometimes we've had to post police actually on the units on 3 shifts or 2 shifts, depending on when they are needed. It causes significant problems because when things go wrong, the staff will be looking at the police to manage the aggression. Whereas every intervention has to be led by the staff until the staff does a formal handover of this intervention to the police. So it's not easy, but it could be helpful if patients react positively to the presence of the police. I've seen that happen. We've been able to manage such patients. But on the other hand, if they don't, then you're really back to square one in trying to think about what to do. So quick question about ethics dilemma. I love everything that has to do with ethics. If a psychiatrist working on an inpatient unit is assaulted by one of his patients, in other words, you have a blow to your head that has resulted in hematoma and a small laceration, it's pretty heavy assault. Is it ethical for the psychiatrist to continue to manage the patient's treatment and medications, about discharge planning, and so on and so forth? This, if I could see everyone and you could see me and we could talk, this would generate, as always happens, an interesting conversation about what people would do in situations like this. Bottom line is, are you still able to keep the patient in front of you? Are you still able to make sure that all your treatments and the way you interact with the patient is in the patient's best interest? If everything you can do can still be in the patient's best interest, regardless of how you feel, regardless of transference, regardless, if you can really make sure that you're going to do the right thing for the patient, you're not going to discharge them prematurely, you're not going to give them punitive measures or punitive treatment or punitive medications. If you can do that, then yes, maybe it's ethical to do it. One of the things I find is that as individuals, we sometimes can't see ourselves. We believe we're doing something that is right, but your colleagues will notice that something is different in terms of how you're managing and dealing with this individual now. So it's better to take your cue from your colleagues to get a sense, are you still doing things right or not? Because we are not good judges of ourselves in those situations. So if you can move somebody to a different facility, a different unit, fine, that would be better. If you can move them to a different place, fine. If you can't, then that becomes really difficult. You have to figure out how to make sure that you can continue to do the best you can for the patient. Should the staff press charges after having been hit? Another area that generates a lot of conversation. There are pros and cons to pressing charges. As I said before, first and foremost, every staff reserves the right to decide to press a charge or not press a charge. You can't stop them. You can't tell somebody, listen, you've been assaulted, but I forbid you from pressing charges. You really shouldn't do that. It's the right of the staff to do that. But it comes with difficulties. If, for example, you're lucky, you press the charges, the person gets sent to DOC, and they don't come back, then you're lucky. But what happens sometimes, they go, then they come back to your unit, and you know that they are going to be upset. On the other hand, even after pressing charges, they might not be sent to DOC. They're still on the unit with you. Now they know that you want to send them to prison, and you're working with them, and you know how that can be really difficult very quickly. You might have to, change units or move staff or move patients, because it's going to be really hard to continue to work with somebody that you have already pressed charges against. Very difficult. One other thing I learned is that the prosecutors are even not happy to send somebody. They're very reluctant to send somebody to prison, because they say to themselves, and they say to you, well, he's in a hospital where he needs to be, right? Why do you want to send him here? He's exactly where he should be. And so you've done two things. Patient knows you've pressed charges. The prosecutor has refused to move them, and you're living with them on the unit. So very uncomfortable, very difficult. We've talked about long-term use of restraint seclusion. They are no longer acceptable. Be very careful about that. Police security on the units, we've talked about that, who's in charge. Access to the World Wide Web, this is just something that I'm beginning to talk a lot more about these days, and it's really difficult to be in this world at this time and not have access to World Wide Web, especially for people who are in a hospital where they're going to be there for a long time. I'm not talking about acute care hospitals where maybe you'll be there for a month or 2 weeks or 3. But if you're going to be somewhere for years, then it really becomes difficult to not learn the skills to navigate this world with World Wide Web and all of that, the internet. However, the risk is huge. We can talk a lot about the risk of what type of intervention here. So really, I think this is about, trying very hard to come to the end of this. There are lots, just some references here, and I'm going to leave this page for people. Let me see. I hope I was able to cram all of this into 1 hour. There's a lot to say. I'm sorry if it was too much for you guys, but Charles, I will stop here and wait for questions.
Charles, that was just perfect timing. An incredible presentation. I frankly know that we would be happy to spend 2 more hours talking with you and listening. But let's see, I have a lot of questions, and I know we're not going to get them all in, but I'm going to try to be efficient about it. And just to remind people, you can say I'm getting emails, you can put something in the chat, you can raise your hand, and Bill will let me know if you do that. We're going to start, and this is somebody I know you know, Dr. Hank Schwartz, and I'm going to unmute him. I know that he has a question, comment. And Hank, are you there?
I'm here, yeah. Charles.
Great, I can hear you.
Great to see you again.
Thank you.
I wish you were actually here in person. And thank you for just an absolutely terrific presentation. What a mastery of the subject. We're lucky to have you in all of the roles that you play here in Connecticut. So from the point of view of the general psychiatric hospital, the issue most germane, really to us in our practice, is getting the patient who is too violent for the general hospital psychiatric inpatient unit into Whiting. That is not an easy thing to do. And we follow several different pathways. Sometimes it's just a referral to CVH with the hope that from CVH, somehow the patient will get to Whiting. Sometimes it's pressing charges. The police often don't want to cooperate with that. We get our attorney involved to call the Hartford Police Department, and that lights a fire under them, and maybe the charges do go forward, and there's an arraignment, and we hope that sometimes we can influence the judge at that arraignment or the prosecutor for the disposition to be, to Whiting from that point. But these are all indirect methods that make us feel like, we're kind of squirming around out there. hoping that that whiting will be the solution to what can be, a very, very challenging situation for us. Often our staff have been assaulted, sometimes very seriously. So what advice do you have for us with regard to this question? When the patient is just too violent for us, people are getting hurt, or we're predicting somebody will get hurt, and often our predictions are pretty good, in that area. What's your advice? What's the best path to follow to get such people to whiting?
Thanks, Hank. This is a really important question. I've been lucky that I have gone through all the different stages of being an attending in whiting, and then being a leader and the director of whiting, and now the medical director of DEMA. So I've seen all the different levels. In my experience, a lot of, and I'm going to answer your question in a minute, but I just want to preface that a lot of people who are acutely aggressive, sometimes it could be because they are coming down some PCP or some other drugs. Couple of days, they get better. But in those couple of days, significant dangerous activity could happen. That's one group. Another group are people that are, they've stopped taking their meds. They really have decompensated, but there's a clear psychiatric disorder that is leading to this dangerousness. Those individuals can be quite acutely dangerous in the short term, but sometimes, if we're lucky to be able to start them on medicine early, in a week or two, that dangerousness will be less. And the last question is somebody for whom there's an urgent need to transfer them out of general hospitals. Whiting is the last place to transfer a civil patient, because there's actually a commissioner's policy, DEMA's commissioner's policy, that says that the individual, every single attempt has been done outside of maximum security, and those attempts have all failed before this individual can be brought into whiting. The direct person to call when you have an issue that you think might require state hospital is actually my office directly. It's, I work with, Simi Whalen, who many hospital people know. She's the director of admissions for DEMAS, but she works in the medical director's office. That's who to call. We go over the case, she and I, and we make, we ask questions sometimes. Sometimes I call the doctors to go over some of the issues with them. Many, many times, those people end up in a state hospital bed and not whiting bed. Because actually, in my experience in whiting, I can tell you that 90% of the people who come straight into whiting are better in 2 or 3 days. Sometimes they just walk in and they're fine. And it's exactly what I was telling you before about it can be too dangerous in one setting but not in another. So many times, if the hospital where they're coming from, the general hospital, has not had enough time to show that they have tried all these things and they haven't worked, then the next step for us might be to find a state hospital bed for them, where we can attempt some of those things. And if they don't work, then maybe go to whiting. Sometimes I've had to move people straight to whiting for all kinds of reasons. I've listened to the story. I understand this individual because, I can tell you now that it's very hard for me to not have experience with someone's aggressivity just from having lived in this world for so long, to be able to understand where somebody might be better served than not. So the answer to you, the direct answer to you, is actually to call my office if you have somebody that you think is really aggressive. And Jim O'Day and some other guys do that all the time. So that's the way to go.
Thank you, Charles. We're not going to get to all the questions, and I'd like to keep with this in a little bit. In some ways, be interesting, but let's move. There are a number of questions, Charles, that I would say really to people just absolutely in loving your kind of, I would say, recovery orientation toward the work And one of the questions is, can you speak a little bit more specifically about the role of peer support? Do you have experience with that? We have been moving more and more into that space here at the Institute of Living and in our system. Do you have ideas about how that role can expand and your experience with it?
Yeah, I have experience with peer support. I love peer support, and I would say that I was certainly in a forensic institution, I was at the early stage of fighting the battle to bring them in. And I've seen these peers, very good peer support guys, connect with our patients in the way we can never connect. They just don't trust us enough to be able to connect with them in that way.
Right.
We have an individual whom I treated when I was a line doctor, who was, very, very psychotic, very dangerous, almost killed somebody. It took a while for the probate court to approve involuntary meds. I mean, each time we went back, they said no, and so on. But finally, they approved after many months. And he got better. He moved on to less secure. He's now in the community. You have never seen a more effective spokesman for treatment, for care in the hospital than this individual. I mean, he called me, he told me, all the battles he fought with me when he was acutely psychotic, he talked about it later on. And some people whose path have included going to prison as a result of mental illness, ending up in the hospital and so on. Those guys, the peers, the kind of experience they bring in managing individuals can be very significant. Now, on the other hand, you as the clinician, you still have responsibility for your patient. So your ears must still be out to understand when maybe some advice might not be good enough or might be problematic. So the task is to bring this peer support individual in and have conversations with them in a way that will be mutually beneficial to the institution and the patient, but mostly the patient. So I have nothing but positive things to say, so long as you pay attention to some issues. Now, there are peer support trainings, here in Connecticut. I know you guys have one as well. But I love them. That's just my bottom line is they're extremely useful.
Excellent. And I'm going to switch gears with this next question, Charles. Can you share if there are any particular methods that you rely on to determine dangerousness, screens, assessment methods, et cetera?
Well, obviously there are all kinds of screens, but I think the most important screening is actually history, right? History of dangerousness, increased potential for dangerousness. Type of dangerousness in the past. What type? Also, gives you a hint what might be coming down the pike. A history of intellectual disability and dangerous histories that suggest that whenever they are off meds, they try to burn down their house. That's a problem. And so on. Sometimes tickets in prison. So if somebody is in DOC, you want to know how many tickets they got in prison and what types of tickets. Tickets are disciplinary things that you have when you're in prison. And it could be all kinds, they're under different levels. And if it's related to dangerousness, what type of dangerousness? Was it an assault? So you also get that history as part of your so thorough psychiatric history, past history, records, creation, all that will give you a sense where you're going.
Excellent. I'm going to switch back. I'm going to just read a little bit. Really enjoyed this comment, your emphasis on empathy, trauma-informed care, psychology is an integral part of treatment, comfort rooms, being proactive, not reactive. And, particularly doing that in the high risk setting of the, state psychiatric system. And it sounds as though there's a lot of cultural work that you had to do. And the question basically is, what is your learning? What are your words of advice around, how do you get buy-in, is the question, because it can't be just one person. So, how were you able to go from the unit that had the most restraints to the one that had the least restraints? You couldn't do that alone.
Absolutely. By the way, the lecture on the unit that has the most restraint to the least restraint is a lecture that I give to fourth-year residents in psychiatry, and it's like 2 hours, could be more. There's a lot to say. Obviously, no one person can do things. What I found when I was in training, even in England, is although no one person can move this needle, you need a point of the spear, right? You need an individual who's the most significant driver of change, right? Who can move the other guys to come along with you, right? So when I got to Whiting, for example, I trained in England. In my 3.5 years or whatever in England, I did not see mechanical restraints even once.
Wow.
I worked in intensive therapy units. I worked on all kinds of things. Now we had different kinds of medications. You could say there were chemical restraints. Fine, you can say all of that. But I never saw mechanical restraints until I came to the US. So I was in a unit where people were in restraints for a year and a half. I knew we could do without restraints, whereas nobody else knew that, right? Because nobody has lived the experience of no restraint. So the challenge for me was how to bring people along and how to do it. But I needed, a dedicated psychologist, social worker. You need to be able to move people. One of the things that DMAS had been doing for a while is the embrace of recovery movement. The recovery movement, when Commissioner Kirk was in charge, there was all kinds of things related to education around recovery, around the movement, to all agencies in Connecticut. It became more or less like it was a task for him. And that seeped into all our systems. The question was always how to bring that recovery movement into maximum security, because people often saw themselves as different, because of the lingo, dignity to fail and all that to failure. People could not translate them in forensics because the last time they failed, they killed somebody. So you want to be careful. However, it's doable. It's really how do you adapt the principles into your care. It definitely needed a commissioner level intervention approach. It's going to need leadership to buy in, leadership effort to spread it to everyone, and so on. So yeah, a lot of things are involved in it.
And I seem to remember when talking with you about this before, coffee. What is that? Is there some story about coffee? Like you would bring coffee or have coffee?
No. So that's I don't know if I want to. Okay, so that I only have 2 minutes. Yeah, that's one of those things. I'm going to say it very quickly. So this was one of the times when I was on that unit. Each time I came onto the unit very newly in my role as the attending psychiatrist, there would be 2 patients in restraints. They had gotten into a fight at shower time when they are doing shaving, and they are doing all kinds of things, small space. I want to shave, you want to shave. I'm get into a fight, and then they get into restraint. So I was wondering how to break this thing. I keep wondering, how could I just change that paradigm so that I could come in the morning and I've been in restraints. I thought long and hard. Finally, I got an idea. The idea, because I knew our patients loved coffee. At that time, a coffee that was being served patients was the decaf coffee. Somebody said, regular coffee would increase violence. I didn't know where they got that from. Did my research. That was so I decided that they were going to have regular coffee. The patients were ecstatic. Oh my God, you're going to give us coffee? Yes. However, there were conditions, and one of it is no fights in the last 24 hours or 12 hours, no restraints, and so on. And everyone was agreeing to do that. Then I went down to talk to my third shift staff. I said to them, here's this fantastic idea I have. we're going to brew coffee for these guys. We're going to make it a news group so that early in the morning, we'll all sit around and watch the news and drink coffee and so on. But in order for you to qualify, you need to be free of violence. You guys, you need to make the coffee. And they said, no, we're not going to do it. And one staff member who's a nice young lady looked me straight in the face and says, Doc, with all due respect, we don't serve coffee to criminals, which was how they saw Whiting at the time. Now, let me just tell you, Whiting is a completely fantastic place. My experience at the beginning was it was in a process of change, right? Mm-hmm. It has changed now. It's fantastic. So that was when it was in the process of change.
Yeah.
Nobody would say that today. Anyway, they didn't. So I made the coffee myself, and, they were watching me make it. I came early in the morning, 5 a.m., made the coffee, got the patients in. There was no restraint. I made the coffee for one. There was no restraint early in the morning for 1 week straight. And so they knew it worked. I went back and I begged staff. I begged the head nurse on third shift, please help me. This is working. Let's do it. And so the nurse took it, did it. And that was the end of early morning restraints, just simple interventions like that.
I love that story. I love that story. And we're out of time. So it's a great story to end on because it's a story about leadership. It's a story about a particular kind of leadership. It's definitely a story about you, Charles, and what you bring to the work. And back to what Hank said, I mean, I agree. We're very lucky to have you as a resource here. And, as if it didn't need to be said, but, you've not chosen, not that any of us has, but you choose to work where it's difficult to work, right? I mean, you're not choosing to do things because they're easy, but because, they're difficult. This edge that exists between psychiatry and criminality, and there's just so much suffering there, and so much that does not work well there, and that's where you're spending your energy and already having a huge difference. So, on behalf of all of us here, I just want to thank you for the time you spent with us. Thanks everybody for participating. Bill, thanks for your help with the tech, and Vanessa and Ron, thank you for your work getting these grand rounds together. And with that, Bill, we can stop the recording.